Thank you very much, the organizers. Thank you, Viraj, for this invitation. And I attended the previous talk also. It was a wonderful discussion and debate on the neoadjuvant therapy versus upfront surgery in resectable tumors. And we hopefully will have a good discussion on management of borderline resectable pancreatic cancers as well. So I'll just share my screen. My screen is visible?
Yes. Yes, it is visible.
So I have a very good panel which has 4 surgeons and 1 radiation oncologist and a medical oncologist. And to begin with, just in brief, the borderline resectable pancreatic cancers have identified. Mainly this categorization happened in the last decade or 15 years or so. These are about 10 to 15% of cases of all comers pancreatic cancers, because majority are either locally advanced or metastatic. Only about 5 to 10% are resectable when they come, but these are about 15% of tumors. And there have been various definitions or labeling of these tumors, which has been variable, and now maybe it is getting streamlined more and more. So my first question to the panelists will be considered as a borderline resectable tumor. I'll start with Dr. Vikas. Dr. Vikas.
Yeah, good afternoon. And
Hi.
yeah, good afternoon. Hi, Dr. Bhandare. How are you? Am I audible, Dr. Bhandare?
Yes, you are. So what exactly would you consider as a borderline resectable tumor?
So borderline resectable tumors, most of them we categorize radiologically on the basis of their on the basis of the pancreatic tumors and their interface with the vessels. And for the head tumors, it is the interface between the pancreatic tumor and the superior mesenteric vein and the portal vein interface. If it's more than 180 degrees, it's considered borderline resectable. And for the arteries, if there's an involvement of the gastroduodenal artery, or there is a small focal abutment which is amenable to reconstruction for the hepatic artery, and for the vein also the same criteria apply. If we have a tumor that is amenable to resection, which can be resected and which can be reconstructed safely, both proximally as well as distally.
All right. Yes.
And then we can have the other criteria as according to the functional status of the patient, or yeah.
Right. Absolutely. So there is a clear-cut categorical definition. Mainly what we follow, most of the people now what follow is the NCCN definition, but there are a number of other definitions also. And I think what is important is that they have separated the head tumors. The criteria for borderline resectability for a head lesion is different. And similarly, the same for the body and tail tumors is different. So basically, vein involvement of more than 180 degrees or the artery abutment of less than 180 degrees is borderline resectable. And anything which is beyond that is locally advanced, which is at present. But actually speaking, all tumors who have a high risk of margin positivity are actually borderline resectable. That's how the definition, the genesis of definition was that these patients have a high risk of having a margin positive resection. That's how they are called as borderline resectable. So even if some patients do not fit into these criteria, they still actually are borderline resectable, which are less than what is defined. So they come into resectable disease, like vein abutment of, say, for example, 90 degrees or so, but there is no artery abutment. So technically this is a resectable disease, but still in these cases, that particular area, focal area where there is a high risk of margin positivity could still be borderline resectable. These are not defined yet, but maybe in future this can come up. Dr. Vikram? This is anatomical criteria, of course, but beyond this, what you would see as a patient when you plan for surgery versus something else, based on what criteria when you see them at the first visit.
Yes. So there are two other criteria which I know Manish will share in the next slide probably. That there is a conditional criteria and there is a tumor marker criteria. So basically, if the patient's CA19-9 is significantly raised, so these are the patients where there is chance that there are significant micrometastases present, and the prognosis in these patients is proportionate to the rise or increase in the CA19-9 levels. So CA19-9 levels after drainage are important values. And the third is the performance status of the patient and the extent to which the patient will tolerate oral therapy, maybe may it be a chemotherapy, or may it be a surgery or oral therapy. So the performance status of the patient and the tumor marker CA19-9 levels are the two important biologic and conditional criteria, which are also important along with the anatomical criteria, which already Dr. Manish mentioned. Yes.
Right. So it's not only the anatomy, you have to look at the patient as a whole and how the anatomical criteria. So I'll start the case. This change to also,
Dr. Manish, your network is unstable, I guess.
which was adeno.
Manish is not audible.
Dr. Manish, your network is unstable, I guess.
Yes, I'm so sorry for that. Is it clear now?
Now it's clear, sir. If you can switch off your camera, your video, it will enhance your voice quality, sir.
I will do that. I will do that.
Thank you, sir.
Okay. So the case is a 45-year-old gentleman. Stent was placed because of obstructive jaundice. CT scan showed a mass lesion which was in the head of pancreas. Abutment of SMA and SMV was present. An EUS guided FNEC was performed, which confirmed an adenocarcinoma diagnosis. The tumor marker was high. CA19.9 was 1650. And these are the CT images, which shows, pardon me for these images because I only have the arterial phase. That's why the portal vein is not completely looking filled with the contrast. It's not a thrombus, but the portal vein was only aborted. The SMA was also aborted. This is the portal vein which is aborted, and that's the mass lesion which is seen in the head pancreas. There was no metastatic disease. So in this case, what would you think? What would you approach? And also my question to Dr. Manish Gandhi will be, this patient underwent an EUS guided FNAC. That will be always preferable, or would you not do a biopsy in such cases? Or if you have to do, can you also do it by CT scan guidance?
Thank you, Dr. Manish, for asking the question. See, first of all, looking to the images, I feel that if you see on the right side of the screen, the disease is going behind the superior mesenteric artery also. I think I feel so. So the metallic stent in place, large tumor medial to that. And looking to the CT scan, I feel that I'll definitely go for the biopsy because of the locally advanced, we would say it's abutment of the SMV portal vein and SMA. I feel that this may require some kind of neoadjuvant therapy. So to get the biopsy proof, I'll definitely go for a EUS and get a EUS guided biopsy. At the same time, I'll inform my gastroenterologist that they will correctly show me or give me information about that disease and its relation to the major vessels. I never prefer CT guided biopsy when you have availability of the US guided biopsy. I never ask for CT guided biopsy.
All right. Yes. Okay. So this patient, as you said, yes, there is a component of tumor which is close to the SMA, and as per the report, the involvement was up to 120 degrees for superior mesenteric artery. So the tissue diagnosis is achieved, and then he is recovering. He has recovered from the obstructive jaundice, and now he is looking fit. His appetite improved, his nutrition improved, the jaundice resolved, of course. And now what is the next plan which will be offered? Pawan, you are there? Dr. Pawan? Pawan or Vikram? If Pawan is not there,
So the plan would be for most of the patients of, so now this is a clearly borderline resectable pancreatic. Am I audible, Manish?
yes, very
Yes.
much.
So this is a clearly borderline resectable pancreatic cancer. As you said, the portal vein is just abutted, and there is around 180 degree of SMA abutment. Probably the disease was also reaching the jejunal vessel. But yes, it is still defined as borderline resectable pancreatic cancer. And in this patient, we are concerned about the margins on the SMA and even on the vein. If the patient's performance status is good after, yes. So we'll try to achieve the tissue diagnosis as just mentioned by Dr. Gandhi with the endoscopic ultrasound. And then my approach would be to start with a neoadjuvant chemotherapy. Most of the times the therapy starts with neoadjuvant chemotherapy. And depending upon the performance status, the choice would be between FOLFIRINOX and obviously Gemnapacli. Our medical oncology colleague, we obviously add to it. And after around 4 cycles, we usually reassess the response. More often than not, the patients, yes, I know there are different approaches, but yes, after 4 cycles, we reassess the response. If there is a significant radiological and biochemical response in the form of reduction in the tumor marker or improvement in the plane or along the vessels, either we would consider for surgery or the MDT will think about whether to add radiation to it or not. So addition of radiation is every time an MDT decision. But yes, we will start off with the neoadjuvant chemotherapy in this patient after achieving a tissue diagnosis.
All right. All right. And also, I think Dr. Gandhi also said that he would also prefer neoadjuvant chemotherapy. Dr. Vikas, before I go to the radiation and the medical oncologist, amongst the surgeons, I see 2 surgeons already are saying borderline resectable NACT. So there is probably not much debate in this, but Vikas?
And looking into the advanced GA99 levels also are quite high, 1650. So after staging, we might do a staging laparoscopy, and then we might send the patient for a neoadjuvant chemotherapy.
Yes. Of course, the CA19-9 is also high, but the patient also had obstructive jaundice. So at times there is also possibility that once the jaundice resolves, you can repeat the levels to check the CA19-9 in. Okay.
Sorry
So
to interrupt you, Dr.
NACT
Manish.
or NA. Yes, Dr. Manish.
Yeah. The other point of that, in this kind of tumor, I feel that looking to the CT, it looks like that it may be a biologically quite aggressive. So by avoiding surgery in this patient and adding a neoadjuvant chemotherapy, my other point is that we'll come to know how the tumor biology. And suppose if even though you give a neoadjuvant chemotherapy and tumor progresses, then I think you may escape from the surgery in this patient. So, and if it is good responding, then you can plan for surgery for this kind of patients.
Yes, that's the rationale. But now, neoadjuvant therapy, yes, everybody is agreeing to neoadjuvant therapy, but which neoadjuvant therapy? Will it be only NACT? If it is NACT, then how many cycles of NACT? Would you just continue longer, or add radiation based on some interim assessment? Dr. Suhas and Dr. Indu, your viewpoints on it.
I think Suhas has not joined, so I'll
Yes.
just take the question on chemo.
I had joined. I think I had
Oh,
joined.
he came back. Okay, great.
So I think.
All right. So, Dr. Suhas, which one? Which chemotherapy?
So as
For
we
a
know
fit
that.
patient who.
So as we know that the role of the neoadjuvant therapies in the potentially resectable pancreatic cancers they are evolving as of now. And now when we come to the neoadjuvant chemotherapy, although the best regimen is not currently defined as such, but when the patient performance status and the comorbidities can support us, so the modified FOLFIRINOX will be the best suitable regimen. And when the patient won't be able to tolerate that, then maybe we can consider the gemcitabine based regimens.
Okay, so how long would you give? How many therapies cycles would you give?
So after
Will it be
starting,
4?
so after starting the treatment, we would like to evaluate the patient at 2 months, after 2 months of the starting the treatment. And based upon the responses, we can take it forward from there, whether to add, whether to continue with the few more cycles or whether the addition of some more neoadjuvant radiation treatment in the settings. So at least 4, but not the cycles, number of the cycles, they are not definitely fixed as such. Based upon the responses, we can take it forward.
Okay. And Dr. Indu, would you also like to radiate this patient, especially now in the wake of the Alliance trial results? What is your take on radiation therapy for such kind of lesions?
So, Dr. Manish, I would say that definitely I would be very happy to add on radiation after maybe 3 to 4 cycles of chemotherapy. One thing I wanted to know from you is what was the status of lymph nodes? Because it was not mentioned in
Yes, the
any of the
lymph
slides.
nodes were not involved. There
Lymph
was no
nodes were not involved.
lymphadenopathy seen.
Okay.
No.
So this patient, I would definitely be very, very keen to add on radiation, because in this patient, radiation would not only help in, it would, of course, definitely by giving chemotherapy, we are downstaging the tumor, decreasing the risk of micrometastasis, but radiation would definitely lead to more of R0 resections. And with FOLFIRINOX regime and gemcitabine and Abraxane based regimes, R1 resections have definitely, R0 resections have definitely improved with the addition of radiation. And specifically in this patient, as you said, that lymph nodes were not there and the patient shows a very good response to chemotherapy, then maybe SBRT, stereotactic body radiotherapy would be a good option rather than a long course or protracted course of chemotherapy. And after that pre-PONC trial, it has definitely shown that radiation adds to benefit. So long course radiation has not shown much responses, has shown local responses, but not much advantage in terms of in terms of overall survival. But pre-PONC trial and few other data is emerging, which shows that SBRT definitely leads to increase in local control, decrease in distant mets, as well as increases the overall response rates. So this patient, I would definitely be very, very keen to add SBRT.
This patient you say in particular, but this is suppose this is not so close to the superior mesenteric artery. If it is very only involving a portal vein, would you still be considering radiation therapy? What is your preference to give radiation, and which all borderline resectables would you prefer to radiate, or a particular group of borderline resectables you are more happy to radiate?
So as I said, one is that definitely if the mesenteric SMA is involved, then definitely radiation would add on to further benefit, because now there's some data is emerging where they say that for SBRT, you can give, say, 30 to 35 grade to the pancreatic lesion, and at the same time you can give a simultaneous integrated boost to the lymph nodal areas or to the vessel tumor interface. So in those cases, definitely SBRT helps. So people have tried, if you give only RT to the pancreas, it may not add too much benefit, but if you take care of the lymph nodes and vessel tumor interface and give a higher dose to that area, it adds to benefit of with radiation and leads to better R0 resections.
All right. Yes. So there is no very clear data on radiation. Of course, there are mixed reports, but I think
So radiation would
radiation still
definitely
has.
lead to decrease in local control. So if you add on radiation, it would, rather than just chemotherapy, if you add on radiation, it would definitely lead to increase in local controls also and R0 resection.
All right. But are the surgeons also happy to radiate, or the surgeons would have some concerns?
As an institute policy, we don't usually subject our patients to pre-op radiation, but we do get a fair share of patients from other hospitals who are radiated. And what we have observed intraoperatively is that there is a little bit more of fibrosis, but there is less vascularity, and the pancreas tends to be a bit more firm. So we are more happy doing the anastomosis with a radiated pancreas. So not much of an issue.
So I'm happy, Dr. Vikas, you made that statement in favor of radiation.
And they are definitely less vascular.
Yeah. So the point that I want to make here is that as compared to conventional radiation, where say 3D CRT or IMRT based regimes, now that with SBRT being focused radiation, the chances of toxicity are much lesser. The chances of duodenal perforation or bleed, they are also much lesser. So SBRT definitely has an edge over protracted long course radiation, and moreover SBRT does not delay your surgery, or it does not so if the patient is showing a very good response to chemotherapy, we have taken care of the micrometastasis, and then to improve the local controls, we should add radiation. That's the point that I want to make. And if SBRT is available, it is definitely a very good tool with very less toxicity. So the toxicity is not much higher with addition of radiation.
Manish,
Right.
can I ask a question?
Yes, sir.
Manish, a couple of things. Are we going to look at the trend in reduction of the CA99 level in terms of considering whether this patient is responding to our neoadjuvant chemotherapy or not? Because RECIST is not going to be useful in imaging this patient whether he has responded or not. And second, of course, in this patient, as Dr. Gandhi mentioned, that we would be concerned about the tissue or some doubtful area beneath or behind the SMA. So what would be the view of the panel?
Yes, exactly. That's what is my next question, that how would you assess a response in these cases when we put them on neoadjuvant? Would you just do a triphasic scan? Would you do a functional scan like a PET CT? Or would you serially also monitor the tumor marker levels, which is CA 19.9? Vikram?
Yes, so I think it is a combination of both. It is usually a triphasic CT scan and both tumor markers. So we would like to see a significant reduction in CA 19-9 levels if they were already raised in the beginning. And if they were normal, probably it's not going to help unless it is raised again. So that is one thing. The other thing is a triphasic CT scan, a cross-sectional imaging in the form of pancreatic protocol CT scan is what we follow. And that's our preferred method. There is, if you have done a baseline PET scan, maybe another PET scan can give you some idea about the reduction in the SU uptake, but that's not the common practice and probably not a standard of care as far as response assessment in pancreatic cancer is concerned. Yes, so our assessment would be a cross-sectional imaging in the form of CT scan and tumor marker. And one of the catch-22 situation usually, Manish, as you know, in the clinic is if the CA19-9 has gone up and if the tumor bulk has not reduced and the tumor is still borderline resectable. and then what we do, or tumor is still locally advanced, but where there is a possibility of surgery in future. And that's the difficult situation for the clinic, I think. Yes, but this patient seems to have responded.
Yeah, so as you can see, this patient, in view of the time limit, I think I'll just rush through a little bit so that we discuss a little more later. So this patient received 6 cycles FOLFIRINOX first because the tumor markers did not come down after the initial 3 cycles of chemotherapy. So another 3 cycles were added. Radiation also was added. We do frequently use radiation at Tata Memorial also. More so for locally advanced disease, less so for pure borderline resectable, but some of the borderline, yes, we do. And then we got a very good response in tumor markers. The radiological disease was stable at this SMA region, but if you can see, the portal vein plane was very well maintained. Now it was more or less free from the posterior part of the portal vein. And now what is the next plan of the panel? Dr. Manish and Dr. Pawan. I think Pawan has also joined.
I'll ask the medical oncologist and radiation oncologist both that is that patient has achieved the maximum response to the chemotherapy, because whenever I'll ask for a neoadjuvant therapy, I'll discuss with the medical oncologist that whatever the cycle 4 or 6 cycles which you are given, you feel that the response which you got it's optimum. If say that yes, then I think I'll proceed for the surgery. And in looking to this scan also, as you mentioned, that portal vein phase looks better compared to the previous images, and still the arterial images I am near the artery disease, I am not still happy. So if there is no further chance for reduction with the chemotherapy.
So before them, I would say that the tumor marker response we have achieved. The CA99 has come down to 150. So there is a good response, and the patient is also fit. So if we see anatomical, biological.
Hello. Hello.
Yeah, go ahead, Dr. Manish.
Yeah, but I think there is a problem in the connection. Yeah, I seen that CA19 has significantly reduced, but looking to the CT scan, that's why I asked that. Still, I'm not happy with the disease which surrounding the SMA. So I'll discussing with the medical oncologist, and I'll discuss with the relatives and patients also well that I may proceed for the surgery. But the thing is that there's chance that I may have a difficulty near the SMA, and may possibly that I may have not good margin also. And if everything goes fine, then I will proceed for the surgery.
All right, so proceed for surgery. So I'll skip this one, and this patient underwent surgery. Portal vein resection was done, and the R0 resection was achieved. But my question to Dr. Pawan is, when we do the portal vein resections, can you just quickly enumerate what are the important areas of your concern are and how you deal with this area of involvement? Or Dr. Vikas, if Pawan is not available.
For portal, for cases where we are anticipating a portal vein resection, most of the cases we plan with an arterial first section, and we first make sure that the artery is free. We generously use frozen sections, and if there's any tissue which is adherent to the SMA, we send it for frozen, and if it's negative, we proceed with this. Then now in most of the cases, we are using the total mesopancreatic excision technique. And for portal vein resections, first you have to start with a generous cattle brush manure, so that the length of the SMV, what you get, you will always get a good length of the SMV. Then, as far as possible, try to preserve the splenic and the coronary vein, because we have seen in certain cases where the coronary vein has been resected, the stomach tends to get a bit congested, and we might have to resect a portion of the stomach as well. And then the SMA should be preferably clamped before applying the clamp on the portal vein, so that the bowel congestion decreases and you have less incidences of leaks with your anastomosis. And further, you can mobilize the liver. So as far as possible, we try to achieve a primary anastomosis of the vein. If it's not possible, then we may use a peritoneal or a PTFE graft. And sometimes we need to even mobilize the liver to get the portal vein down, so that to decrease the length. And the clamp time has to be less. The lower clamp is to be released first. These are all the technical issues what we routinely follow.
Dr. Manish Bhandare, we have 2 minutes left only.
Yes, yes. So thank you. That was about the portal vein. Then when you have diseases which are close to the artery, as we had in this case, just to run through this quickly now in view of time, there can be a potential halo sign or a string sign when we see the radiological images, which just means that the tumor is either encircling the artery or there is any wall involvement. You can make out that in the CT scan, which has a good sensitivity. And depending on that, you can either have a possibility of divesting the vessel, which you see in the right image, where there is a free plane after chemotherapy and radiation. The disease is looking that way in CT scan, but when we actually go into the periadventitial plane, you can have a plane where you can separate the tumor completely and still get an R0 resection. Or at times when there is wall invasion, you may have to do a small segment SMA resection. Of course, larger segments are generally not preferable because, as we discussed, these are not so good biology diseases. But when you have the other responses like tumor marker response and a fit patient, of course, there are few areas where you can have. Now, if we get an R1 resection as per the new protocol, not R2, but an R1 resection, and we have not used a neoadjuvant radiation in these cases, what would the panel say? Will it be only adjuvant chemotherapy? This is a bad biology disease. Despite a good neoadjuvant chemotherapy, we still have not got an R0. It's just margin is close but not involved, less than 1 millimeter but not involved. Would you prefer a radiation in this case or just give chemotherapy, Dr. Suhas?
So since the means the patient has not received the neoadjuvant radiation and the R1 resection, I would be inclined towards the using the adjuvant CRT in this setting.
Adjuvant CRT. And Dr. Manish, you would also add a radiation for such cases if you get, or you would say this is a bad biology tumor. Anyway, the morbidity may be high. Give only chemotherapy.
Yeah, I don't prefer adjuvant chemo radiation. I prefer only adjuvant chemotherapy.
Yes, so that is also, I think, a point, because at places we have had results that margin is positive. We aim to achieve now something where we have already missed a bit in the pre-operative phase. And now giving radiation generally doesn't help much to the patients. We do this often, but the long-term results doesn't seem to reflect the same, that we don't achieve much if we give radiation in this setting. Dr. Indu, what is your experience with such cases?
So I would also agree with that. So if the patient had lymph nodes also positive post resection, and it was a clear-cut positive margin resection, then definitely radiation might have helped, but not with just a close margin situation. I think then chemotherapy would be a better option.
All right. Okay, so thank you so much, Dr. Jagdish, Dr. Viraj.
No, thanks, Dr. Manish. It was a very good discussion. Dr. Kothari sir is there.
Yes, yes.
You want to
So-
make a final comment on the presentation?
I think
I make just one small comment. I mean,
Please,
why I was talking about radiation was because it has been seen that along the perineural nerves, the perineural spread happens along the superior mesenteric artery and the venous system. So that is where radiation helps in improving the local controls. And some studies have shown that pre-SBRT, if the CA 19 point levels are low, say around 90 or 100, then the results are better. Just 2 points which I wanted to add.
No, we also completely agree. In fact, we were a little skeptical to begin with radiation, because when we dissect so close to the SMA, there is no problem in giving as much as you can in a disease like pancreatic cancer in the beginning. But the surgical concern was always that whether it would weaken my arterial wall if I do a close dissection to the artery, which would lead to a potentially life-threatening post-operative complication. That was the fear or scare.
Yeah.
But now with the experience after giving therapies, we are much happy. We have not seen any increased complications apart from some high rate of chyle leak, because the lymphatics do get thickened, and then the leaks also heal a little delayed from the lymphatics. But apart from the chyle leak, there has been no bad experience.
Yeah. So,
So
Dr.
far.
Bansal,
And it has not
you know,
been reported also world over that this is.
yeah, Dr. Bhandare, please go ahead.
No, I'm done.
Okay. So, Dr. Bansal, one thing all surgeons would agree that the best pancreas that we would like to stitch is post radiation. We feel so comfortable that this anastomosis is going to stay. Otherwise, we have always apprehension. Other than that, probably this was the best moderated panel, Dr. Bhandare, and all the panelists had excellent inputs into this debate. And thank you so much, Dr. Bhandare, and all the panelists.
Thank you
so much.
Thank you, sir.
Thank you.
To everyone.